Hi, I'm Doug Major. I'm an optometrist practicing at 4 offices in San Luis Obispo County, California, with my lovely wife Nancy, who is a certified vision therapist. I've had an interest in special populations, particularly those in the corrections. Just recently became a Z Health trainer. This is a paper that was presented at the KRASKIN OEP Invitational, January 2001. The paper's title is The Neurology of the Pepper Stress Test, or What Can We Learn from the Emerging Field of Functional Neurology? Well, what is the Pepper test? Well, the Pepper test was introduced by Bob Pepper, the man with the trampoline. And essentially, it was established by holding the scapula of a patient with one hand and then actually torquing the shoulder back with the other. Usually you would try to torque the shoulder with the eye with a problem, usually a suppression issue or amblyopia. The interesting thing that happened is while you were doing this isometric torque, oftentimes the individual would see the two strings on Brock string or have an improvement of their visual acuity if they're amblyopic. I got interested in this because of a tape that came after a College of Optometry of Visual Development, the COVD meeting. Back in the day, we used to have a video, or no, instead of video, we would have a cassette tape that would come back talking about the different lectures. And one of my favorite was presented by this man, rest in peace, Stephen Kuhl. Stephen Kuhl was worked up at Pacific College of Optometry, was an occupational therapist, I think, but did a lot of research. And he described a dialogue with this man over here, Roger Dowis, who practices in Boulder, Colorado. And I called Roger to make sure I got the story straight, and let me share it with you. So Roger and his friend Ron Bateman attended one of Bob Pepper's wonderful seminars, and he was talking all about movement, and integrating movement into therapies. And Roger got sort of tired and raised his hand and said, "Hey, Bob, when are you going to talk about binocularity?" Which most optometrists, of course, work on. And Bob just said, "Oh, I just fix it like this." And he demonstrated the Pepper test. Well, Bob and Roger and Ron were livid that they'd spent all this time and really hadn't learned a lot about binocular vision. They actually started the Colorado Vision Forum, their famous esotropic book. But they did try it. And so they had a difficult patient and tried the Pepper test on, and lo and behold, the person broke their suppression. So Roger decided to write a nice paper about that, presented it in the presence of Steve Kuhl, and Dr. Kuhl said, "Roger, I really like you as a person, but how can I ever believe that your eyes are connected to your shoulders?" And Roger sort of wirily came back and said, "I'm just a clinician. I just do what's best for my patients. Dr. Kuhl, you're the visual scientist. Why don't you tell me why it works?" And so with that question in mind, and I listened to that tape so many times, that's always plagued me since the 1980s. Why? What caused this type of response? Well, the answer is forthcoming, and unfortunately not through the channels of optometry, but I would suggest through the channels of functional neurology, chiropractics of specialized training. And particularly this Dr. Eric Cobb has been very helpful for me personally to understand what's going on. Eric has started the Z Health program, Z Health University, and he has now thousands of athletic trainers following in his protocol of integrating neurogenic or top-down therapies for movement. So he's a movement expert. Also information from Dr. Cedric Knoll, another functional neurologist who came up with Focus Builder, an interesting app that highlights the power of ocular movement. And an early adapter in optometric field is the current NORA president, Dr. Deanne Fitzgerald, who has the Brain Eye Academy. I would suggest, as we think about this, many of us have this instrument or right eye that what carefully evaluates eye movement skills. And we're going to talk about how that's connected with the Pepper test. I would suggest to anybody to go ahead and look at the web pages for all of these individuals, Dr. Cobb's, Cedric, and Deanne. Great information, free and at a moderate cost. So there are many among you that are saying, what are these functional neurologists doing in our sandbox, in the vision sandbox? I just want to remind you, we have a very, very big sandbox, and we don't have a lot of our colleagues playing with us. So I look forward to what we can learn from those who are the new entries into our vision sandbox, and hope that we can all work together for the betterment of our patients. So let's begin with what Z-Health would suggest as neurology simplified. Nervous system does three things: receives sensory input, decides what to do with that input, processes it in the brain area and other areas, and creates a motor output, usually, or a thought output. So the brain needs two things to stay alive. It needs the fuel of oxygen and glucose. It's a fuel hog, of course. And it needs activation. The brain needs activation. If the brain does not have activation, the neurons will seek it or die. I like that example of the primates where they go ahead and connect two fingers together, and almost immediately the brain starts treating that as one because it doesn't have the separate input. A brain needs activation. And understanding activation is to understand how the brain has a feeding pattern and how it activates. And the key point here is that things are next to each other, neurologically activate each other. There's definitely a lot of cross-sharing, and there is a method to why things are located in different areas of the brain. So let's get right to it. In brain stacking, from the top down, you have a midbrain that visually works on the far and near invergence and are associated with flexor tone. Next, the pons that has the abducens and the vestibular cochlear, more of the extensor tone. Remember, the pons has that connection that goes directly to the cerebellum that's also mostly extensor tone. And then further down, the medulla that has more of the workings of the basic body chemistry and that's more of a flexor tone. So Pepper upregulated the motor system to change vision outputs with the test. He wanted to change the successive binocular therapies. Cobb and others upregulate vision systems to change motor outputs. That's so important to understand. So Cobb and others use this ability to become better movers. So what about immediate application? Well, because we know that there's flexor tone in the midbrain, let's suppose we want to converge. Again, a flexor movement, which essentially is pushing forward on your neck while you're attempting to converge, could be a very powerful way to stimulate better convergence. And similarly, if you have to diverge with an ESO deviation, extending out, probably from the top all the way down to your heels, has been shown to be helpful in helping direct the eyes outward. That's like the classic story of A.M. Skeffington looking at the child with their eyes crossed, getting on a train track and looking up and the eyes straightening. So on a movement point, move your eyes up, facilitates extension, move the eyes down, facilitates flexion to the right and to the left. And so Cobb uses these neuro integration to actually improve. For example, if you want to improve extension, you're going to go ahead and move your eyes up as you do activities that require more extension. And again, we can reverse engineer that into what we do with vision therapy. So what's the neurological jobs? The first one, of course, is survival. Question would be, is the body more oriented towards survival or performance? And definitely it's oriented towards survival. The fight, freeze, flight, fetal position, the fear, flexion that occurs. I always like that example. If you can't remember what flexion is, think what happens in the fetal position. Down, in, up with your hips. Survival processing can be summed up in 2 words: pattern recognition, or with correct pattern recognition, prediction of the future. Accurate prediction reduces threat, the pain, the risk, and for older people, reduces falls. And what happens when the brain can't predict accurately? Well, pain, weakness, fatigue, nausea, all those things when there's mismatches. So let's talk a little bit about this stacking as it applies to neurology, and particularly the fight or flight, or the rest that just feed and breed. I always had a question about, why do we need 3 ocular control muscles for our ocular motor nerves and muscles? Why do we need 3? Why couldn't it just be in one? But when you start thinking in this idea of threat and relaxing, it makes sense. So of course we have the trochlear in the flexor area up here. So think of that, if I'm fearful, I'm going down, my eyes are going down and in. And the one that's the furthest off is, of course, way down on the abducens, more in the pons, is the lateral rectus, which is more of the feed and breed and, pound my chest. Second thing neurologically we're looking at is movement. And, movement starts with frontal lobe with the voluntary movement, but look how much happens behind the scenes. The cerebellum, fixes errors, and then the PMRF is that always on for the posture and global control and autonomic response. Again, location. It's fascinating that horizontal eye movements are more on the neurointegrators in the medulla, vertical in the midbrain. So there's definitely a difference in how they activate and how we can tease out the best in therapeutic results as we work with our patients. It requires a correct body map to get good sensory information. And so that clear information from the vision, which is predominant, vestibular and proprioceptive, is so important to integrate where we are in space and our perception of our body. And just as body maps come from those receptors in joints and muscles, visual maps come from receptors in the extraocular muscles and the retina. And that retinotopic map that flows through, even in our superior clickless and other areas, these body maps are everywhere, and we need to learn about them and exploit them. So with this concept, the retina is the only part of the brain that moves. I'd like you to consider the eyes as a complex coupled joint that needs to be explored, enhanced, and mapped as we move our eye brain in all different directions. When mismatch occurs, the consequences are sometimes dire. Reduced predictability, that increases threat. And of course, that happens when you're on a boat, or motion sickness causes tension. And the sort of our age, the anxiety and depression, when these mismatches occur, people know there's something wrong. They just don't know what to do about it. Now, this is the unique, I think, contribution of Dr. Cobb. Inaccurate brain and sensory motor mapping can be assessed by immediate changes in flexion and extension. Again, this assessment and reassessment by immediate changes in flexion and extension, range and accuracy of that, threat and predictability loss. So I'd like to do one little thing that my personal Z Health trainer taught me. If you want to try this, if you want to, again, just hold your fingers right inside where your neck connects to your skull there. And you might find a little hollow area. And then as looking straight ahead, look to the right and the left. And you will feel activation. Now, obviously, it's inhibited because you don't move your head, but this just demonstrates how directly connected and regulated our eye movement system is to the neck and body orientation system. So again, as I look right, again, my body wants to turn right, but it has to be inhibited. Fascinating, more than a parlor trick. So one of the areas we'll just concentrate on today is the cerebellum. The cerebellum is so important because it's that area where maps are corrected, learned, and stored. And you think about 75% of the cortical area compared to the top down, and 78% of our neurons are here in this little small brain, the cerebellar area. Of course, the cerebellum is used the ABCs: accuracy, balance, coordination. It has those three peduncles that are connected with the three systems: the spino to the spine, the cerebro goes right to the brain, the vestibular direct links to the balance system. This is where it happens. And as suggested in Dr. Ratty's comment, as we see, even our higher brain functions still have evolved from movement and still depend on movement. Movement and brain function, movement and eye function really cannot be disaggregated. So here's a study from Tara Alvarez and Mitch Scheiman and others that really excited me. I was sitting in our academy meeting and was looking forward to some of the neural basis for the CI, or convergence insufficiency studies. And when Dr. Alvarez mentioned this, I literally said, wow. And people around me sort of looked at me and are all quiet, taking notes. The idea that there is this direct neural function, and of course, Mitch is famous for all the work he's done on convergence insufficiency and all the wonderful research. And so now they found a neurological basis. Now, Tara used to just look at the primary eye fields and up the parietal eye fields. Then she discovered all of this activation in the oculomotor vermis. That's in the cerebellum. And then I appreciate her sharing this information with me. This is an example of the activity level pre and post vision therapy. Look at the magnitude in the vermis compared to the frontal eye fields. This is where the action is occurring. This was shared with me also. So if you have a cerebellum injury or gradual dysfunction, your eyes begin to turn in. Now think about that. Why would that be the case? Well, remember, the cerebellum is the extenders. You start taking away that and the eyes will start to turn in. I have almost monthly an older person that comes in describing that they're seeing double at night and are beginning to become esophoric or esotropic. Doesn't this all connect to what we do? So again, the cerebellum is key not only in eye movement, but eye alignment. And this is what we do. For us that have the right eye, we assess the cerebellum all the time. If you have a brain function, truthfully, I have yet to come with anybody with a brain function that doesn't have the cerebellum highlighted as an area of rehabilitation. Why? Because hypometric eye movements are a sign of dysregulation in the cerebellum. Like this right eye, when it's off all the time, usually when it's over, that's a sign of cerebellum. And we can access that and fix it. Here's a comment by Dr. Carolyn Hirsch from Great Britain. Appreciate her sending this information. She's got some great information that she keeps up. But I like this. Learning from the cerebellum induces plasticity in other sites. Induces plasticity in other sites. So in other words, isn't that what we're trying to do? To induce plasticity in the whole brain? What a great concept. And the other thing we talk a lot about is, connections with academic performance as vision therapists. And what happens when you have a damage to the cerebellum vermis? Acquired dyslexia occurs because of the impairment. This study done in Italy. Again, and it's been duplicated and expanded. This was in 2002. This is the action. This is where we need to put our emphasis. The cool thing about the cerebellum, of course, there's just so many ways to access it. We've done balance assessment for years, but never really knew how to integrate that or what it meant, or what if one side's versus the other. And of course, now, particularly after brain injury, Romberg's, sharpened, and with perturbation, all these things are great. Gait, finger to nose, tapping, every joint can be utilized as a cerebellar joint or cerebellar test. So it's so accessible to location to where there's a problem, and that helps us to know what to do and how to rehabilitate with our specialty of eye movements. The Sharp and Romberg, of course, is really just a balance test with eyes open, closed. And the interesting thing that Dr. Cobb and others use is that after doing correct eye movements, Romberg increases dramatically. So just another access point that's so easy for us to use what we do and make sure that the therapies that we are using are helping and not hurting. And of course, now we have this great tool of the sensory motor system, the right eye. And as we look at the right eye, we can tell where is the area, superior, inferior, right and left, where is the area of concern. This information is valuable for us to know where to put our therapy efforts. So, cerebellar contributions to eye movements. Just remember, it's intimately involved in real-time, immediate modulation of gaze shifting, gaze stabilization, as well as long-term calibration and adaptation of those skills. This is where the learning of eye movements is stored and used to help in the future. And again, they don't even use the word reactive anymore. Preactive. This is where it plans on where you're going to have to put your body and your eyes and how to protect yourself. So where are the areas of interest? The vestigial oculomotor region, flocculus and paraflocculus, the flocculus region, nodulus and uvula. I did an interesting search for the last time they had the neuroscience national meeting, and there was over 440 papers under ocular motor cerebellar. This is the area of interest. Tremendous amount of new research. How can we apply that for the betterment of our patients? So let's look at the three areas. The vestigial oculomotor region. It's most active in acceleration and deceleration. It's also associated with saccades, that we are not going to address today. The flocculus region. Eccentric gaze fixation, to hold. Maintaining pursuits, like a Marsden ball, not the starting and stopping. And then the angular type of VOR. And the nodulus and uvula, more for the linear or translational. And that's more up and down, and then that vestibular membrane. So we have all these direct starting points. And obviously, if you have a direct area in the brain that's isolated for that skill, that's how we can use our therapy to go to that isolated area to make sure it's working, and then also to rehabilitate. And the other cool thing is that these are directionality specific, meaning moving your eye muscle in one direction or the other will activate different areas or different sides of the cerebellum. And so again, particularly the FOR is that initiation pursuits in the downward direction, and the flocculus, the horizontal and the vertical, diagonal, And interesting enough, torsional, we can actually access the torsional part of eye movements, which is a very difficult thing. I haven't seen anyone else attempt to do it in this fashion. So let's start off with that fixation, gaze fixation. And let's think of our eye as a joint. We have to explore and work on all the different directions. So as we look straight ahead, and I appreciate Mike Golden for all this information, as we look past 20 degrees, we actually have to inhibit our head from moving. So we can hold in each of the cardinal points. And then if we find areas of difficulty, let's suppose flexion or something on one side, Dr. Cobb would suggest that we go ahead and let's suppose we have to increase extension. If we look up while we do that extension, that's going to help activate extension, just like we demonstrated with our eyes. Again, fixation, so vital. And then pursuits. Some of the ideas that Z Health has presented to me as far as pursuits, this idea of the stopping and starting. We use pursuits pretty much like a Marsden ball, but we need to do starting and stopping. We need to have it change at different times, not causing saccades, but keeping the faster and slower. And then again, let's suppose we want to increase directionality, looking just to the right, shutting just the right. So isolating directionality area gives us powerful tools to again help our patients do better. So again, here's another example of the flocculus. So again, acceleration, meaning if I want to accelerate to the right, if I start here, I got a little push to go to the right, right? Because I have that little rubber band helping me. Now, what if I want to make it more difficult? Well, if I start already 20 degrees here and go to the right, that's going to be more difficult. So the opportunities are really endless of how we can use different areas of the FOR and the flocculus to work on our eye movements. Again, down, torsional, fascinating. So just to simplify, for fixation and smooth pursuits, the flocculus and paraflocculus helps the eyes move in the opposite direction of the ipsilateral, horizontal, and anterior canal VORs. We didn't talk about VRs where we have to essentially, with the cancellation, turn off the input from our canals and make our eyes be the leader. But again, another area that we can really work on that is beyond this. I just want you to understand the complexity of this and this idea that this is just a beginning step at what I'm presenting today. And under the FOR region, speeds up the eye movements in the opposite direction and slows down. So that initiation is a completely separate area than the maintenance is the important thing to understand. And again, we can get associated with saccades in another lecture. So this wonderful sheet talks about all of the implications for therapy. You might want to get a screenshot of that, and allows you to go. We didn't really talk about the otoliths, but again, up and down, just like Dr. Pepper. You think Dr. Pepper's whole addition to vision therapy was the trampoline, Mr. Sacuel, and doing that as an access point to really neurologically wake us up and help our eye movements, as well as so many other aspects of our neurological landscape. So let's get back to the Pepper test. Is there neurology between the shoulders and eyes? I think I've already shown you one, but here's a great study: neck response to shoulder muscles, and this direct connection through the superior colliculus to the neck muscles. And as you see something of interest, that even before you move your eyes, you're going to have these this onset of changes in the neck, changes in the deltoid, and interesting enough, changes in dopamine. And so for those who work with syntonics and color, they'll like to know that this neurotransmitter also changes. Isn't it fascinating? So here's some, again, some more studies shared to me by Mike Golden. Direct connection with the neck rotation and the flexion torque. The EMG activity preferential to those muscles ipsilateral to the direction of the rotation when they talk about neck responses. And then just some great graphics that talk about when you see something and how much goes through and re-goes through the flocculus that goes back to the eyes for eye adjustment, for VORs, and so many other things. I'm not going to spend time on the superior colliculus, but just where, obviously, if you change the superior colliculus, that changes motion and binocularity. A key place, this idea that you can stimulate certain parts of the superior colliculus map and cause, again, esotropic problems or exotropic problems. Again, a lot of management and misalignment occurs there. So the superior colliculus, again, is just this really important spot. But again, going back to that adjustment and readjustment, all of the PRF, the flocculus, paratheflocculus is indicated here. As you see the amount of work that goes into eye movements, we cannot forget the cerebellum. And here's some other ones. The effect of muscle fatigue on dynamic visual acuity in young adults. Again, muscle fatigue connected to how well you can see, and diminishes with, again, cervical spinal position measurement error. And this one on posture stability and accessing balance with strabismus and amblyopia. So if balance is associated with strabismus and amblyopia, and even moderate cases can lead to posture instability. The eyes are directly connected to posture. And I didn't get into this, but just get a feel for the complexity of all the eye movements, and then, again, stimulating semicircular canals along with that to drive the eye movements, or vice versa, to fix semicircular canal issues. This volition versus the reflexive is such a powerful tool that we can use once it's understood. So to end, Dr. Bob Pepcher's clinical observations and practice has strong neurological support and evidence, and the Pepper test works because of the neurology that supports it. Again, to finish, I think we all need to strongly consider connecting with a movement therapist. And somebody like Z Health has been extremely helpful in our particular area. Personally, it's helped me and my wife tremendously. And so just the cognitive background that's available to us. And so I'd suggest you go ahead and look. Again, there's now thousands of Z Health practitioners. Look in your area, locate somebody. We've always been looking for someone when we're done with vision therapy, or when we're done after a traumatic brain injury. There's still so much needs to be rehabilitated on the movement. And now we have somebody that's, I think, speaks our language and in our court to help these people to get the best outcome for our patients. And again, so thank you everyone for your attention, and appreciate all the help from Z Health and others who've helped with the slides. And I'd like to appreciate those who allowed me to present this at the KRASKIN, and hope to see you sometime in the future. Thank you.